Good morning to one and all. Today I am presenting my thesis topic, a comparative trial between trabeculectomy versus phacoemulsification with or without angle surgery for glaucoma and nanophthalmos. So as we all know that nanophthalmos is a condition in which the axial length of the eye is less than 20.5 millimeter without any ocular malformation. Such eyes are predisposed to angle closure glaucoma. They also have a shallow anterior chamber, a narrow angle with a high lens to eye volume ratio. Surgeries in these eyes are associated with extremely high complications.
Dr. Ria, please be ready.
The rationale of the study is that there is very limited understanding for the standard
Dr. Avik
procedure
Kumar
for
Roy.
intraocular pressure control in these eyes, as the epidemiological data is very less due to the rarity of the disease. Also, as these surgeries are associated with high intraoperative and postoperative complications. So, we thought of doing a study to compare the safety, durability, efficacy of different surgeries to control pressure in these eyes. So from the studies from the past, we have seen that there was no evidence existing which says which surgery is better for controlling pressure in these eyes. There was no biometric cutoff available for deciding the procedure of choice, and there was no comparison done between trabeculectomy or phacoemulsification with or without angle surgery for management of glaucoma in these eyes. The primary objective was to find out the assessment, was to assess the profile and severity of glaucoma in these patients, and also to find out the efficacy and safety of surgery in lowering IOP in these eyes. So we did an ambispective study at our center. We recruited patient, and the absolute success was defined with IOP less than 18 mmHg without the use of glaucoma medication, and qualified when we use medications. Statistical analysis was done. We recruited 41 eyes of 34 patients, 18 eyes in the trabeculectomy group, and 23 eyes in the phacoemulsification with or without angle surgery group. These were the preoperative data which was comparable in both the groups. We saw that there was a reduction of IOP in both the groups, but the IOP reduction in the phacoemulsification group was 51% at least 1 year after surgery, with a mean IOP of 15.4 millimeters of mercury. The survival of the surgery, that is phacoemulsification, was much higher when compared to trabeculectomy. Also, the vision was improved in the phacoemulsification group, and we saw that at least 13 eyes gained 2 or more lines of logmar vision, whereas in the trap group, the vision dropped by 2 or more lines in majority of the patients. The number of medications to control IOP was significantly reduced in both the groups. However, we saw that the eyes which underwent TRAB were using 1.5 times more number of medications. The absolute success was achieved only by the phacoemulsification plus minus angle surgery patients. None of the TRAB patients would achieve absolute success. And also, the number of re-interventions was significantly higher in the trabeculectomy group. We also found out that eyes with a chorioretinal thickness greater than 1.7 mm was associated with the complications 1.5 times more than the normal CRT thickness. So we conclude that the phacoemulsification with or without angle surgery is more effective and safer means for managing IOP of eyes in these patients. Long-term studies are warranted to look for the results. Sample size was small owing to the rarity of disease, and also as it was a multi-surgeon approach and cases were recruited from past, so these becomes the limitations of my studies. Thank you.